Yeah.
We good? We're recording?
Yeah.
Okay. So today we're going to talk about renal pathology and then the OSCE stuff. So clin skills in terms of history, exam, and also dipstick, which you have to know how to do. Pathology-wise, there's sort of three main big things: glomerulonephritis, AKI, and CKD. And then there's a couple like miscellaneous little things. But we'll start with glomerulonephritis. So glomerulonephritis refers to a whole collection of diseases involving immune-mediated injury to the glomerular filtration barrier. So it actually includes like 10 to 15 conditions, probably more. And you don't have to know all of them, but there are a few that you have to know. And they're very buzzwordy. So it's really just a matter of knowing the buzzwords. But the way to think about glomerulonephritis, which they don't teach you in second year for some reason, is to think about where the pathology is. So we know that there's three components to the glomerular filtration barrier. You've got your fenestrated capillary endothelium here. And remember that the whole thing with fenestrated is that it has gaping holes in it. So it doesn't really stop anything. It's not much of a barrier. So you've got your fenestrated endothelium. Then you have the glomerular basement membrane. And the function of the glomerular basement membrane is to stop cells moving across, specifically red blood cells. And then you have your podocyte foot processes on the very outside. And they have they're charged, and it stops the negatively charged proteins from moving through. So then you can imagine that if you get damage to your basement membrane, that's when you get hematuria, because the red blood cells can suddenly get through. Versus if you have podocyte damage, that's going to cause proteinuria because the proteins can pass through. And hematuria and proteinuria form the basis of your nephrotic and nephritic syndromes. So glomerulonephritis, you learn two sort of classic, like a dichotomy, nephrotic and nephritic as the two presentations. In reality, it's sort of a spectrum of the two. So nephrotic is on one end, and that's where you've got primarily podocyte damage. So because you've got damage to the podocytes, the protein can get into the urine, so you have heavy proteinuria. Because you're losing protein in your urine, you get hypoalbuminemia. And if you have low protein in the blood, you have low capillary oncotic pressure, which gives you edema. And these are all like the 4 O's as a way to remember them. The last one's kind of weird. So when you have low albumin in the blood, the liver tries to compensate by just making more stuff. So you increase the hepatic lipogenesis, and it actually just makes more fats. And that's why you also get hypercholesterolemia or hypolipidemia. In nephritic syndrome, you've got basement membrane damage. So that's letting the red blood cells through, which means you get hematuria, classically Coke-colored urine. And then because you've got all of this damage to the actual glomerulus, there's a compensatory mechanism where it constricts to reduce the blood flow to that glomerulus. And if that happens on a larger scale across your kidney, then you end up with oliguria, which you can remember is hardly any urine. And if you have oliguria, you get fluid retention. So you do also get edema in nephritic syndrome. You see it in both. And particularly hypertension, again, relating to that fluid retention. So nephrotic syndrome is 4 O's, nephritic syndrome is 3 H's. But the main differentiating thing is protein versus blood in the urine. And then you've got this sort of third category, which is rapidly progressive glomerulonephritis. And it's kind of just when like the damage is really bad and really sudden, and you just get rapid failure. Everything just goes to shit. So you have hematuria and proteinuria, and you get scarring and cirrhosis in the glomerulus. And it's like this characteristic crescent appearance on biopsy. And there's 3 things that cause rapidly progressive glomerulonephritis, and we'll go over each of them. But you've got anti-glomerular basement membrane, lupus nephritis, and ANCA-associated glomerulonephritis. So this is probably the most important set of diagrams for all of glomerulonephritis. So here you've got your nephritic versus nephrotic, and this is, remember, thinking about your capillary endothelium and then the basement membrane, and damage to that causes hematuria and nephritic syndrome. And then outside of that, your podocytes, and damage to that causes proteinuria and nephrotic syndrome. And remember I said that all of your conditions, your glomerular diseases, they're on a spectrum of proteinuria to hematuria. There's sort of a couple over here at this end, which are entirely just proteinuria, and so you just get nephrotic syndrome. And then you've got ones over here which are largely hematuria, but you also still get a little bit of protein, because when you get damage to the basement membrane, your podocytes are sitting on the basement membrane. So if you damage the basement membrane, the podocytes, they get a little bit of collateral damage. So you get hematuria as the main feature, but there's always going to be a little bit of proteinuria as well. And we'll basically just go through each of these conditions here on this spectrum. So you need to know these three, your classic nephrotic syndromes. You need to know these three, your classic nephritic syndromes. And you need to know these ones up here, SLE and IgA nephropathy, which present as a little bit of a spectrum. You don't really talk about MCGN or amyloid much in second year. And diabetic nephropathy, you kind of just have to know in the context of diabetes, which we'll talk about in endocrine. So let's start with your nephrotic syndromes. So there's three: minimal change, focal segmental glomerulosclerosis, and then membranous nephropathy. So minimal change disease, the big buzzwords I have put in bold, so it's nice and easy. Minimal change disease is the most common cause of nephrotic syndrome in children. If you see nephrotic syndrome in children, it's probably minimal change. The pathogenesis is unknown, which is good because you don't have to learn it. And the pathology, this is really important, it's called minimal change disease because it looks normal on light microscopy. So on light microscopy, you don't see any change at all. And that's because the change is microscopic, even more so than light microscopy. So you need electron microscopy, and you see fusion of the foot processes or effacement. So this is normal foot processes poking up above your glomerular basement membrane. In minimal change disease, they just sort of fuse and blob together along the basement membrane. And that would be diagnostic of minimal change. This one is probably the best nephrotic syndrome to have because it's very responsive to prednisolone, and it very, very rarely progresses to like chronic kidney disease. This is usually just something that people manage lifelong. And you'll see prednisolone is basically the go-to treatment for like the majority of your glomerulonephritis conditions, because a lot of them are immune mediated. So that our response is just to try to suppress the immune system. And that's what prednisolone does. Focal segmental glomerulosclerosis. So this one is sometimes called the dark side of minimal change, apparently. Its pathogenesis is also unknown. But if you think about the name, it kind of tells you what the pathology is. So focal means that it affects some glomeruli, but not all glomeruli, right? Focal areas of the kidney. Segmental means within the glomerulus, it affects certain bits of the glomerulus, but not necessarily the whole glomerulus uniformly. So it's parts of parts. And then glomerulosclerosis, sclerosis is like scarring and fibrosis. So the pathology that you see on biopsy is scarring of some parts of some glomeruli, and it's literally in the name. So this is kind of a diagram, I guess, of a normal glomerulus doing its filtration. Here you've got scarring of a little bit of the glomerulus, but the rest of it is still functional. There are some things that are associated with this, but you don't really have to know them in much detail. And again, the treatment, we try prednisolone, but it usually doesn't work. So this one is pretty bad because it almost always progresses to CKD. Even if you get a renal transplant, it tends to recur. And so there's not much you can do. It's kind of just a matter of controlling blood pressure and hoping to slow the progression. But this one it's pretty bad, basically. And then your final nephrotic syndrome is membranous glomerulonephritis. The important thing to know for this one is that it's the most common nephrotic syndrome in adults. So children, minimal change; adults, membranous glomerulonephritis. It's an autoimmune disease. So this one we actually do know the pathogenesis for. And what happens is you get these autoantibodies that deposit under the foot processes. So here you've kind of got a diagram of a glomerulus. You've got in orange your endothelium, in red your basement membrane, and then the blue things are the podocytes with their foot processes. And these antibodies sort of deposit in between the podocytes and the basement membrane. So remember, if you're damaging podocytes, that's when you get nephrotic syndrome. So here you get all of your nephrotic syndrome to a slightly lesser degree than minimal change. But the classic finding is diffuse fibrosis and thickening of the basement membrane. Again, if you think about the name, it kind of makes sense. It's called membranous glomerulonephritis. So it makes sense it will also affect the membrane. but it's a nephrotic syndrome. So the principal damage is to the podocytes. You just see this thickening of the basement membrane. And then in terms of prognosis, this one is kind of in between minimal change and FSGS. So there's a third rule where a third will remit, so essentially recover, a third will continue at the same sort of level, and then a third will progress to CKD. And again, you try prednisolone for the high risk subgroup, because prednisolone long-term does have a lot of adverse effects. So some people just spontaneously remit, and in that case, you wouldn't want to be giving them prednisolone. So that is your nephrotic syndromes, those three there. And this is kind of a hierarchy in terms of how severe the proteinuria is. And then on this end, we have our nephritic syndromes, post-streptococcal, small vessel vasculitis, also called ANCA-associated, and then anti-GBM. And again, this is a hierarchy of increasing amounts of hematuria. So we'll start off with post-infectious glomerulonephritis. Again, you think about the name, it kind of tells you the pathology. So this occurs after a streptococcal infection, usually in children. And it's most commonly your strep pyogenes, your group A beta hemolytic streps. So if you remember learning about rheumatic heart disease as a systemic complication of chronic rheumatic fever or recurrent rheumatic fever, this is another one of those complications. I think it was called like the non-suppurative complications or something like that. So this is one of the complications of strep pyogenes infection. It classically occurs 2 weeks after a throat infection or longer after a skin infection, and you just get sort of a mildish nephritic syndrome. It's not too bad. And essentially what happens is, again, you get antibodies depositing. So these were antibodies formed against the streptococcus, and they sort of deposit this time closer to the basement membrane, so in between the endothelium and the basement membrane, right? So it makes sense that this time they damage the basement membrane, not the podocytes, and so you get hematuria, not proteinuria. Occasionally, some of them make it past the basement membrane, so remember you get some collateral damage all the time. So hematuria principally, and then a little bit of proteinuria. What you see on biopsy looks like this, and essentially it's just like proliferation. It just sort of looks a little bit more crowded than the normal one. And if you do immunofluorescence staining, you can actually like see immune complexes, right? And that tells you that this is like an immune-mediated damage. This is largely a temporary problem. It self-resolves with time once the antibodies have been cleared. If it's really bad, you can do temporary dialysis to try to clear things out faster. But essentially, it's just supportive treatment, fluids, whatever they need, and then it'll go away by itself.
As a point to add to that one before,
that time frame is really important. So there's 2 weeks after throat infection, sorry, and this 3 to 6 weeks after skin infection is really important to differentiate it from IgA Glomerulonephritis. So this 2 week time frame is quite buzzwordy as well. So just keep in mind, if they come in perhaps saying they had a throat infection, they got better from it, and now they came from their urine or getting bleeding through their urine, it's pretty buzzwordy from post-infectious GN.
Yeah,
just as a side.
And we'll get to IgA nephropathy, and you'll see it's just a slightly different time frame. Okay. Oh, and also the different antibodies. So this one has IgG, whereas IgA is a separate. Okay, and then we get into ANCA-associated glomerulonephritis and also anti-GBM. So these two are 2 of your 3 causes of rapidly progressive glomerulonephritis, the really bad one. So ANCA-associated affects older adults over 60 years, and it's due to autoantibodies to neutrophil proteins. So that's the ANCA. And ANCA causes a vasculitis, and with vasculitis, you get constriction of the arteries going into the kidney. And as a result of that, you get necrosis because it's like not enough blood supply, not enough oxygen, and you get ischemia. ANCA-associated glomerulonephritis can also affect the lungs, and you'll see that with anti-GBM as well. So basically these 2 are like the worst, like you just don't want those. So it rapidly causes renal failure, and it does also affect the lungs, and you get pulmonary hemorrhage. The pathology that you have to know is that you get this glomerular crescent formation. So pretty much whenever you see rapidly progressive glomerulonephritis, very bad glomerulonephritis, you get crescent formation. And what happens is basically the immune response triggers proliferation of these fibroblasts around the outside of the glomerulus. And they create this sort of fibrin crescent that essentially like it squishes and suffocates the glomerulus, like it can't function because this is completely impaired. Again, you try immunosuppression, it's sort of the go-to. Occasionally you try plasma exchange to try to get rid of the neutrophil antibodies, but that would have to be lifelong because this is a genetic condition. Prognosis is really bad. 85% will die in a year if not treated, which is a very short time frame. And again, it's because this is rapidly progressive. But even if you do treat them, a lot of them still die because prednisolone, again, high dose prednisolone is quite rough. It severely suppresses the immune system and they end up dying from infections and things like that. So it's kind of a lose-lose situation. And then we have anti-GBM, so anti-glomerular basement membrane. Again, the name tells you the pathology. So this is an autoimmunity against the collagen in the basement membranes. And the reason it affects the lungs too is because the kidneys and the lungs are made of the same type of material in their basement membranes. They both have type 4 collagen. And so if you have antibodies against this collagen, then you're going to be destroying both the kidneys and the lungs. So this is a rapidly progressive glomerulonephritis, and it causes lung hemorrhage, and that will present as hemoptysis and dyspnea. So blood in the urine and blood in the cough. This is called Goodpasture syndrome, the combination of the two. So if that pops up, that's what this is referring to. And again, you get the same sort of pathological findings, necrosis and crescent formation. So this is what a crescent looks like on a biopsy. So normally you've got this sort of outer capsule, and then the glomerulus sort of fills the space, and you've got a nice gap in between, right? The Bowman space for the urine to come out into. In crescent formation, you can see there's all of this extracellular material around the outside, right? And that's essentially squishing the glomerulus down. And you look at this glomerulus, there's almost nothing left. It's almost entirely crescent, right? And that's really how the damage gets caused in these rapidly progressive glomerulonephritises. You get rapid loss because the glomeruli just get like suffocated by cells. Again, you try immunosuppression and plasma exchange as treatment, but again, the prognosis is pretty bad. Okay, so those are our nephrotic syndromes, our nephritic syndromes, and now we'll talk about these ones up here, SLE and IgA, the ones that kind of present on a little bit of a spectrum. So IgA nephropathy, it seems like it should be very similar to post-streptococcal, and you'll see there are some similarities. And it does present as a range of nephritic syndrome. So it's nephritic, but with sometimes microscopic hematuria, and then sometimes macroscopic hematuria. That's really the spectrum part of it. And then SLE is related to lupus, which basically can do anything along the spectrum, which is very fitting for lupus because lupus is that kind of condition. So IgA glomerulonephritis. This is also called Berger's disease, and it is the most common glomerulonephritis, like out of all of them. The hematuria here, it can be microscopic or macroscopic, so that's why you've got the bit of the spectrum, and it's associated with infection. And so Kevin mentioned before that the time frame is important because post-streptococcal glomerulonephritis comes on 2 weeks after a throat infection. Here they get it within like 24 to 48 hours. So classically they'll come in and they'll be like, oh, I had a little bit of a sore throat, and then the next day I noticed blood in my urine, right? That's going to be IgA glomerulonephritis because it's a much shorter time frame.
If you ever hear the term synpharyngitic, that's what it means. So it means with the pharyngitis at the same time. So that's the kind of the medical fancy word you might hear about it.
I've never heard of that, but cool. And then the pathology that you get is abnormal IgA. So this is actually an underlying genetic condition. It's triggered by the infection, but it's the underlying pathology is with the genetics. Whereas in post-streptococcal infection, there's no genetic abnormality. It's purely just a product of the infection, right? So in post-streptococcal, the antibodies against the infection, they just happen to deposit in the kidneys and cause damage. Whereas here, a normal person with regular genetics is not going to get IgA glomerulonephritis. It's caused by an underlying genetic abnormality. And what happens is you get these abnormally large IgA molecules. So IgA starts off as like a polymer, and then it gets cleaved into little individual IgAs. Here, there's a problem with that cleavage process. And so you just get these massive IgAs that deposit in the kidneys. And again, whenever you get antibodies depositing in the kidneys, they trigger inflammation. So antibodies will draw, they'll release cytokines and stuff like that, and basically cause inflammation wherever they deposit. So if you get that in the kidneys, you get this same sort of proliferation, hypercellular, crowded appearance on biopsy. And again, that will stain with immunofluorescence because you have antibodies present. So the management of this, the prognosis is, it's okay. A third of them progress. So it's kind of similar to your membranous nephropathy. But the problem is, again, if you treat them with high-dose steroids, it can kill the patient. So treatment is kind of controversial. You're trying to balance the line between suppressing a person enough to stop the glomerulonephritis, but also not suppressing the immune system too much to where you kill them from infection. So if someone is low risk and it seems like they're not progressing much, then you would just aggressively manage blood pressure. Okay, and then the last one is lupus nephritis. And this one, it's pretty easy to identify because they will have systemic symptoms of lupus. Kidney-wise, it's hard to differentiate because it can be anywhere on the spectrum. So it can be very mild or it can be rapidly progressive. It can be focal or diffuse, nephritic or nephrotic. The presentation, you really can't tell. But what gives it away is the systemic presentation. So lupus, the buzzword is young females. Young females get lupus and they come in with this like characteristic butterfly rash across the face with nasolabial sparing, if they ever ask about that. And then there's all sorts of other symptoms as well. So they're photosensitive, they get alopecia, which is hair loss, and ulcers in the mouth and nose. And then you also get joint problems, arthritis, synovitis, and then serositis. So they get heart problems, lung problems, pain everywhere, basically. Lupus is really bad. And if you can think of a symptom, lupus can probably cause it, essentially. It's just very like systemic and vague. So it's caused by a systemic autoimmunity, and you just get immune complex deposition in various places. And in the case of nephritis, you get it deposition in the glomerulus. Again, that causes inflammation and that causes damage. There are treatments for lupus, and it will actually depend on the type. So lupus nephritis has many different types, and you differentiate it on biopsy, and then there's certain treatments for each type. But essentially, you're still going for the overall goal of just immunosuppression. And prognosis is poor unless you treat it aggressively, because nephritis is kind of like it's a bad complication of lupus. So that is really it for the types of glomerulonephritis. This is your overview of treatment. You can probably guess prednisolone is number one. So it's all basically immunomodulation. So prednisolone, and then if that doesn't work, there are other agents that you can use, cyclophosphamide, rituximab. But again, it's kind of like it's a stepwise approach because you don't want to overdo it. If you're not going to use immunomodulation, or if they're not working, you want to also give supportive / general treatments. And the big one is antihypertensives. So whenever it comes to renal disease, blood pressure control is super important because hypertension is one of the triggering factors for like literally any pathology. Okay, so you want to manage blood pressure. Even if they have only like mild hypertension, you want to get it down. So they use ACE inhibitors and ARBs, which Kevin mentioned they have additional benefits. So that's why we choose those versus like beta blockers or calcium channel blockers. And then if they have salt and water retention as a result of their edema, as a result of their proteinuria in nephrotic syndrome, you can also use diuretics. And remember, nephrotic syndrome, one of the other classic features that you see is hyperlipidemia. So you want to manage that as well with statins, because you can't forget about everything else and just focus on the kidneys. If someone has hyperlipidemia, they could end up dying from cardiac disease instead of the renal disease. So you manage everything. Okay, the next one to talk about is
Just as
AKI.
a quick thing to talk about
Mhm.
before to GN. So GNs, I guess two things first. You add the statins as well because they're at higher risk of kidney disease, and kidney disease puts you at higher risk of like myocardial infarction anyway. So that's kind of why you cover the statins as well. And more so specifically about the GNs, I guess like a lot of these slides, if you know what Alina's bolded, you're doing quite well. I don't think like we don't really want to scare you guys into thinking you need like every single thing that Alina's put on those slides, because to some degree that is kind of like what you'll need to know next year. But the reason we kind of gave it to you, I can't really speak with Lena, but it's because we didn't really get it in second year, GM kind of like was a mystery. And we think might be a better way to kind of know what's going on with GNs. And so you don't really have to know it all, but know for sure the bolded bits, and the rest of it's just for context and for understanding what the heck a focal segmental glomerulosclerosis actually means, or what an IgA GN actually means in the context of like medicine. But in terms of your exams, the bold is kind of the important part that you can make, like the diagnosis of the buzzword is the overall thing.
Yeah, exactly. If you just learn the bolded parts, that's really all you need. The rest of it is just so you understand the processes, but it is very much just buzzword based. Okay, any other questions about glomerulonephritis before we go into AKI? Feel free to chat. Otherwise, we'll just move on. So AKI describes, it's really a syndrome rather than an actual diagnosis, right? AKI is caused by a whole host of things, but it's defined as an abrupt decline in GFR occurring over hours or days. That's what makes it acute versus chronic. GFR, if it declines, then you get decreased urine output, and then you get accumulation of fluid and nitrogenous wastes in the blood. So that's your creatinine and your urea. The creatinine is important because that's what we do on a blood test to actually look for AKI. And then urea is important because when you have accumulation of that, that's what causes the really bad symptoms of AKI, which we call uremia. So the diagnostic criteria is oliguria, which is this definition. I think you do actually have to know that number, unfortunately. But basically decreased urine output or elevated serum creatinine on a blood test. And this one's kind of wishy-washy because, as Kevin or Gavin mentioned, I can't even remember, creatinine is largely based on muscle mass. So a pregnant person, for example, will have very different baseline creatinine compared to a non-pregnant person. And a very muscly bodybuilder will have a very high baseline serum creatinine. And you might look at it and be like, oh no, that's an AKI, but that's their baseline. So it's kind of, yeah, you sort of have to compare it to what the regular is. But for an average person, we do have guidelines in terms of what a creatinine should be. And interestingly, serum creatinine only really begins to rise when you've lost over 50% of renal function. So we really only pick up these AKIs once a certain amount of function has been lost. For you guys, the important thing to know is what can cause an AKI. And you just want to think about it in terms of pre-renal, intrarenal, and post-renal. So just like how you learn about jaundice in terms of prehepatic, posthepatic, intrahepatic, similar situation here, all right? If you can categorize your thinking and break it up, it's much easier to remember what's going on. So we'll start with pre-renal. Oh, actually, no, we'll start with clinical features. So this is what you see. I kind of mentioned it here in terms of like what happens pathologically, but you get your fluid retention, and that's going to cause all sorts of problems: ankle / periorbital edema, pulmonary edema, which will give you your dyspnea. And if you've got fluid overload, it can cause heart failure. And so that might present as chest pain or pressure. Sometimes they just come in as like weight gain, but that's probably unlikely to be a presenting sign. You also get electrolyte disturbances because things aren't filtering properly. So hyperkalemia, which can cause arrhythmias, that's a big red flag, and metabolic acidosis. We'll talk more about electrolyte disturbance in CKD because that's more of a late sign. And then uremia, this is when it's bad and you're not getting your urea excretion, and that can present again with a whole host of issues, which we'll go into detail about. AKI, if it's not treated, can progress to CKD, which untreated will cause death, or even treated can probably cause death, unfortunately. So you definitely want to catch AKIs early and treat them aggressively. Okay, pre-renal. So this diagram here is very useful. So you've got your pre-renal, renal, and post-renal causes, and it's broken up according to, well, pre-renal being vascular things, so sort of the supply into the kidney, what's happening when it comes in. Renal is problems with the actual kidney tissue itself. And then post-renal is basically obstruction, things that come after the kidney, so the ureter, bladder, and urethra, and problems along that tract. So pre-renal causes relate to hypoperfusion. That's really the key here. And then you've got a lot of different causes of hypoperfusion. So you can have systemic hypovolemia. So if you just have low blood volume, then it makes sense that you're also going to have low blood volume in the kidneys, and so you're going to have less perfusion there. Causes of that include big hemorrhage or massive burns, where you lose a lot of fluid through the skin, vomiting or diarrhea on a very big scale, or polyuria on a very big scale again. It has to be pretty significant to cause an AKI, because remember, you have to lose like 50% of function in order to actually see a serum creatinine rise. So this is like massive hemorrhage or massive burns. And then you can also have cardiogenic shock. So hypoperfusion can be caused by hypovolemia, not having enough in the blood, or tension, right? If you don't have enough pressure coming through. So that can be caused by heart failure, essentially. So you think about what can cause heart failure. So you can have AMI or ischemic heart disease, which is causing your heart muscle to die and therefore not pump so effectively. You can have generalized left ventricular failure as like a long-standing problem. An arrhythmia can trigger failure of the heart and again cause AKI. Tamponade, because there's not enough space in the pericardium, so your heart can't pump. Or you can have it as a side effect of drugs. So if someone is on a lot of treatments, negative inotropes, vasodilators, overuse of heart failure medications, then you get problems with the cardiogenic pumping, and that causes your cardiogenic shock. The other type of hypotension is when it's systemic hypotension. So it's not a problem with the heart pumping, it's a problem systemically. And that's when you get your massive vasodilation. And if you get massive vasodilation, then your same volume of blood is going to be spread over a larger area, so the pressure will be lower. And that can happen in sepsis. So if someone has a really bad infection and that's become systemic in the blood, then you get sepsis and vasodilation everywhere, or in anaphylaxis, when an allergic reaction triggers that massive vasodilation. Another cause of hypoperfusion is if you block the entry. So systemically, everything is fine. You have enough blood volume, you have enough blood pressure, but if you locally block the entry into the kidney, then obviously you're going to get hypoperfusion. So someone who has atherosclerosis, hyperlipidemia, like really bad arteries, they can just get renal artery occlusion or stenosis. Stenosis just being narrowing, and then occlusion being complete blockage. And if you do that, then obviously you're going to cut off supply to that entire kidney. If someone comes in with anuria, so no urine at all, you have to exclude vascular catastrophe. So it's more likely to be like a complete renal artery occlusion because they're getting no filtration whatsoever. And that's bad because the whole kidney can infarct and die essentially. Intrarenal, this one you have to know less about. I think focus on pre-renal and post-renal. Intrarenal you learn much more about next year. So you kind of know what these words vaguely mean, but don't stress too much about what's sort of going on. So for intrarenal, just think about what is present in the kidney, and then think about that you can have a pathology for each type of thing. So in the kidney, you've got the glomeruli, so you can have problems with those, glomerulonephritis, and inflammation there will cause problems. You have the tubules after the glomeruli, so you can get tubular necrosis, which would be the pathology there. You've got the interstitium surrounding your glomerulus and your tubules, and problems there are called interstitial nephritis. And then you have the vessels, and those problems are called vasculitis, right? So just think about what's present. And then glomerulonephritis, you guys are experts on already, hopefully. And then tubular necrosis has two main causes. So this is where you get a lot of overlap because pre-renal and post-renal issues can actually cause intrarenal problems. So if you're not resolving the pre-renal hypoperfusion of the kidneys, that's going to cause ischemia, and that will cause your tubular necrosis. So when you cut off the blood supply and the kidney starts to die, that's obviously an intrarenal problem, but it's primarily been caused by a pre-renal issue. So there's actually a narrow window once necrosis starts to occur, and you need to like rapidly fix the perfusion problem or the kidney will start to die. And that's when you get longer standing acute tubular necrosis. It can also be caused by toxic stuff. So like nephrotoxic drugs would be the classic one, but then all sorts of other stuff as well that you don't really have to worry too much about. Interstitial nephritis. So always think itis means inflammation, right? So if you have glomerulonephritis, inflammation of the glomeruli, interstitial nephritis, inflammation of the interstitial space. And that can be caused by allergy, infection, drugs, again, similar sorts of things. And then the last one is vasculitis, which again, don't worry too much about. It's a whole big autoimmune topic of its own that you'll learn about next year. Just know that those are the 4 sort of categories of things that can go wrong. And then we get to post-renal. So post-renal, again, is like largely related to obstruction along the urinary tract. And that can happen anywhere along the urinary tract. The idea, though, is that if you have a very significant reduction in GFR, it's likely to be an obstruction lower down, right? Because you're cutting off both of the kidneys. Versus if you have an obstruction higher up, where one kidney is going to be affected, but you'll still have flow from the other. So that can be sort of a giveaway sometimes to the type of pathology. There's all sorts of things that can cause obstruction. So if you just sort of think about the different areas and what can go wrong. So if you look at your ureters, you can get stones anywhere along the ureter. So renal stones will cause obstruction. You can also just get strictures, which are just like constrictions of the ureter. That can be congenital, or it can be triggered by like infection or trauma. And then you've got the bladder. So when the ureter enters the bladder, you can get an obstruction at that entry point. And that can be, again, congenital. We'll talk about Acute in a second. And that's one of those conditions. Or you can have like a bladder injury or a bladder tumor, which will also cause obstruction. When it comes to emptying of the bladder, you can have a neural problem that is stopping the bladder emptying. And then once we get lower down into the urethra, there's 2 main things here. The urethra can be strictured again, or you can have BPH in men, obviously. So if the prostate, which wraps around the urethra, you can actually see it indicated here. The prostate, which wraps around the urethra, if that is undergoing hyperplasia, it's increasing in size, that's going to narrow the space in the urethra here and cause obstruction. The main ones that you have to know about are bolded, BPH, and stones, maybe tumor, but not really so much. And this is kind of a very big problem because your obstruction is going to locally decrease GFR, that is true. But the big issue is that if you have an obstruction, say here, you're going to get reflux of urine up through the ureter. It's going to build up pressure-wise and cause hydroureter here, and then hydronephrosis once it gets into the kidneys. And if you have high pressure urine just forcing its way back into the kidneys, that's going to cause intrarenal disease, tubulointerstitial fibrosis. So just remember, pre-renal and post-renal, they're categories of their own, but they can cause intrarenal problems as well. Okay, the most important one that you probably have to know AKI-wise is triple whammy, right? So Kevin talked about this in terms of pharmacokinetics, I guess. But the idea is that you have ACE inhibitors, you have NSAIDs, you have diuretics, and they are 3 very common medications. But the combination of all 3 together can cause hypoperfusion and therefore AKI. And the mechanism for this is that they act in sort of 3 different places. So if you just think about going in, the glomerular itself, and then going out. So when you're going into the kidney, the NSAIDs are going to constrict blood flow going into the kidney or into the glomerulus specifically, and that's going to cut off supply. ACE inhibitors will dilate to the efferent arteriole. And so if you dilate to the efferent or the exiting arteriole, then that's going to further reduce the pressure in the actual glomerulus itself, right? So you've got low pressure because low flow in, and then you're getting high flow out or high space to flow out. And so that's going to further decrease your pressure. And then if you combine that with diuretics, which are just globally going to cause hypotension or lower plasma volume, that's going to cause the problem in the glomerulus. And the result of all of that is that you have low perfusion through the glomerulus and low filtration and therefore low GFR. And that's probably the big cause of AKI that you guys need to know because they love examining triple whammy. Okay, any questions about AKI before we do CKD? I will take that as a no. Anything to add, Gavin or Kevin? No? Okay. No. We will go on to CKD then. So CKD, chronic kidney disease, it has this definition. So it has to be for greater than 3 months. Remember, the time frames is really the big differentiating factor here. So you've got progressive global abnormalities of kidney function for greater than 3 months. And then these are the sort of diagnostic features that you see. Low GFR, albuminuria / proteinuria, or hematuria, which you might recognize from your nephrotic and nephritic. and then pathologic abnormalities on biopsy. In imaging, you can also just see like small shrunken kidneys, but on biopsy, you'll see things like scarring, or you'll see like shrinkage and all of that. It's caused by an irreversible loss of nephrons. Irreversible is important here. So CKD is a progressive thing. Once it starts, you really can't reverse it because loss of nephrons is irreversible. We don't make any more nephrons after birth. So you're kind of stuck with what you got. And if you're damaging them, that's kind of it. So the main causes of CKD are hypertension, diabetes, and glomerulonephritis. There are other weird miscellaneous ones. Polycystic kidney disease is a big one as well that you guys talk about, but hypertension and diabetes are really your big two, okay? Other things, glomerulonephritis, depending on the type of glomerulonephritis and the level of treatment. But most people you see with CKD, it will be caused by hypertension and diabetes, which is important because it means that CKD is very preventable, right? If people have their blood pressure managed and their diabetes managed well, they shouldn't progress to CKD. People with CKD, they're often asymptomatic in the early stages when their GFR is still sort of able to compensate and they can keep it sort of above 60-ish or above, well, yeah, above 60. But after that, you start getting widespread symptoms. And after that, it's progressive. It will continue to end-stage renal failure. All you can really do is try to delay the progression. So the pathophysiology for each of the causes is here. Glomerulonephritis is basically just an accumulation of damage over time. Hypertension is to do with like thickening of the blood vessel walls, which causes narrowing of the lumen, which causes hypoperfusion, and then you get like RAS activation and stuff. And it's actually a cycle. So the RAS will increase the blood pressure even more because it thinks the hypoperfusion is due to cardiovascular failure. So it's like, let me just increase the hypertension or the blood pressure to increase perfusion, but actually it's the hypertension that is causing the problem because you're getting vascular damage. Diabetes, diabetic nephropathy, high blood glucose can cause reactive oxygen species production, which is not super important, but what is important is that is going to damage the vessels. And these are the classic 4 signs that you see structurally. Okay. Progression. So the problem with CKD is that it is progressive. Once you lose some nephrons, you kind of eventually get damage to all the others. So what happens is the kidney tries to compensate initially by redirecting blood to the functional nephrons, right? It's kind of like when you've got VQ like matching in the lungs. When there's a problem somewhere, your body tries to redirect flow to the other healthy functioning areas. So your blood is redirected to the functional nephrons, and you get hyperfiltration in those nephrons. So you've got more blood, or I guess the same amount of blood, going into fewer nephrons. So there's going to be higher pressure going through those nephrons, right? And that high pressure is eventually going to cause fibrosis and scarring in those nephrons. So they die, and then you're redirecting again to an even smaller subset of nephrons, and eventually you get this progressive failure, right? So that's why CKD is so inevitable. And end-stage renal failure is the final end product of that. It's defined as function that should be less than 10%, not greater than 10%, less than 10% of normal, so a GFR of around 9, and it essentially causes death within weeks to months. You can try to prolong life with dialysis, and dialysis would just be a bridge to hopefully getting a transplant. But if they don't get a transplant, there's really not much else you can do, and you would just be doing palliative care. Okay, so the complications of CKD. This is the highest yield part of CKD. This is what you need to know. And I think the best way to remember it is to think about the functions of the kidney. So what you see in chronic kidney disease is failure of the kidney and therefore issues with all of the things that the kidney is meant to do. So the way that I remember the functions of the kidney is a wet bed as the mnemonic. So acid-base balance, and problems there cause metabolic acidosis. Water balance, so you get fluid retention. Electrolyte balance, so failure causes hyperkalemia. Toxin removal, specifically of urea, your nitrogenous wastes, so problems with that will cause uremia. Blood pressure control, hypertension. EPO production, so erythropoietin is the hormone that stimulates red blood cell production, so issues with that is going to cause anemia. And then vitamin D activation, and issues there will cause renal bone disease. So this list here These are the big sort of signs of CKD and the presentations of CKD that you need to know about. And the best way to remember it is remembering the functions. So we can get into the sort of the pathogenesis of each. I don't think you have to know this in too much depth, but just to have an idea of what's going on and more importantly, how it presents. So metabolic acidosis, one of the functions of the kidney is to excrete protons and produce bicarb. So if you're not doing those two things, you're going to get acidosis. And acidosis causes bone decalcification. So it's going to contribute to your bone disease and also protein catabolism. So people with CKD, they're very cachectic, they're very sort of wasted and thin, and that's because of actually acidosis. I was going to put management there, but I'll get to that. Water retention. So again, one of the functions is to excrete sodium and water. And remember that water follows sodium. So if you're retaining sodium, you're going to retain water. And fluid overload has this classic sort of set of symptoms: hypertension, peripheral edema, so your pitting edema in the ankles, and pulmonary edema, which leads to your dyspnea and also cardiac failure. The management of that is just to restrict fluid intake. And then electrolyte disturbance. So potassium is also excreted in the kidneys. So if you're not doing that, you're going to get hyperkalemia. And this is really important because hyperkalemia can cause arrhythmias and sudden cardiac death. So you definitely want to be aware of this. And people who have CKD, they get ECGs regularly to check for things like this. There is another mechanism, but don't stress too much about that. It's to do with RAS. The main thing is just that it's not getting excreted. And then your toxins. So your toxin, the main one we're talking about is urea, which is your nitrogenous waste product from protein breakdown. And buildup of urea in the blood is going to cause a whole host of symptoms. So neurologic is probably the most important one. They get hiccups, which is something that you actually look for on the exam. They get cramps and they get delirium. And they can also have like seizures and all sorts of weird neurological stuff. They also get gastro problems. So this is something that they might actually complain of. They might say, I feel nauseous all the time. And they might not have any appetite, but that's again related to the nausea. And it's quite horrible. So part of palliative care is really trying to manage the nausea. They get also like weird other side stuff. So pericarditis, reproductive problems. So females might get amenorrhea, and then skin changes. So they turn a bit yellow because of the uremia, and that can actually kind of resemble jaundice. So I guess a fun fact is that the way you differentiate uremic tinge from jaundice is to look at the eyes, because jaundice affects the eyes, and that's why you look for it in the eyeballs, but uremia won't. The other one that they get is itch. So that's sort of, again, buildup of product in the skin. And then your bed, part of the mnemonic, blood pressure. So they get hypertension and you just want to manage that. I mean, it's a cause and it's an effect. So that's why the hypertension blood pressure situation is so bad, because it's really a cycle. EPO anemia. So anemia tends to present with fatigue. They'll look pale on exam. They might have palpitations or dyspnea. They might feel lightheaded, things like that. And that's again because the kidney has its job in producing EPO. So if you're losing functional renal parenchyma, you're not going to get EPO production. And then vitamin D. So one of the functions of the kidney is to activate vitamin D and produce calcitriol. If you have low vitamin D's job is to absorb, or I guess assist absorption of calcium from the gut and the kidneys. And we'll talk more about this in endocrine with the whole parathyroid system. But if you've got decreased absorption of calcium, you're going to get low serum calcium. So the parathyroid glands try to compensate. And you get secondary hyperparathyroidism, and that triggers bone breakdown. Essentially what happens is you have low calcium in your blood. So your body's like, where can I get calcium? From the bones. So it breaks down the bones to try to manage your calcium. So they might present with bony tenderness. And that's why one of the things you do in the renal exam is tap down their spine to look for that bony tenderness. Okay, management of CKD.
For mineral bone or bone disease, it's also termed bone mineral disease or mineral bone disease. And I think it depends on who you talk to, depending on like what they think is more important. But the renal physician that like teaches MMC, I guess, puts a lot more emphasis on the hypophosphatemia. So the idea is that your kidneys fail to kind of excrete that phosphate, and that causes like binding towards calcium. That binding to calcium, as Lena says, lowers your serum calcium, which then triggers the secondary hyperparathyroidism Lena talks about. So if Your lecturers talked about the hyperphosphatemia as being a bigger deal. I'm not sure what Lena's told her, but I think it might just be depending on the physician, depending on what they subscribe to, I guess, a little bit. But they're both like important factors. I think it just depends on what you think is first. A bit of a chicken and the egg situation in terms of how I see it. But they're both like important processes. So if you ever get asked, I think this is going to be happening more next year than like this year. But that hyperphosphatemia is also quite an important concept as well.
I think the phys will make more sense when you do like calcium and vitamin D.
Yeah.
I'll talk about that.
And remember that the acidosis contributes as well. So the bone disease you see in the kidneys, I've put it next to vitamin D, but it's really like a combination of a lot of different factors. The main mechanism is the secondary hyperparathyroidism, but multiple things contribute to that. And the idea with the phosphate is that calcium and phosphate basically always stick together because phosphate doesn't bind to much else in the body. So you've got that calcium phosphate production. And so again, it's like, where can I get calcium? Calcium is stored in the bones, so it tries to pull it out of the bones. Okay, so management. Remember I said that you can't really prevent end-stage renal disease once someone has CKD. So the management is really about trying to slow the progression so you can maximize their lifespan and treat complications so they can have like the most pleasant lifespan that they can have. Slowing progression is related to three main things. Well, really two, but you always have to mention lifestyle modification because they love that. So lifestyle modification, your mnemonic is SNAP, smoking cessation, nutrition / weight loss. I just threw that in there. Alcohol reduction, physical activity. All of that is just going to sort of optimize their health and help to contribute to blood pressure control, glycemic control, and complication management. The mainstay of treatment for CKD is blood pressure and glycemic control. So remember, hypertension and diabetes were the two principal causes of CKD. So you're trying to target those things. If they are hypertensive, you give them ACE inhibitors or ARBs, because remember, those again are kidney protective. And if they're diabetic, you want to treat it aggressively with anti-diabetics to manage their blood glucose levels and keep it within sort of a healthy normal range. Again, we'll talk more about diabetes later. And then treating complications. You really don't have to know this for second year, like at all. You barely talk about management in second year. But I put it in there just for the sake of interest if anyone wanted to know. Again, you just sort of think about what each of the complications are and treat it. For the vast majority of them, it's to do with restriction. So if you have too much water, you restrict fluid and salt. If you have too much electrolytes, you restrict those electrolytes. If you have too much uremia, you restrict protein because it's a breakdown product of protein. And then supplementation of whenever things are low. So if you have metabolic acidosis, you can supplement with bicarb. If you have anemia, you can supplement with EPO. And if you have bone disease, you can supplement with vitamin D, calcitriol, or phosphate binders, which is important if they have hyperphosphatemia. But you don't need to know this for second year. And then when it comes to end-stage renal disease, when they're in that final sort of GFR of 9–10% of function, there's really only two options: dialysis as a bridge, and then renal transplant would be the definitive treatment. If they can't get a transplant, it's just palliative dialysis, essentially. So this is kind of a summary of most of that. I think this doesn't mention every complication, but this is probably the most important ones. So if you know this, you're doing pretty well. Okay, and then now we just come to the last sort of miscellaneous random stuff. So renal calculi, you guys talk about just because it's a common sort of clinical presentation and it's pretty easy to spot. But you get stone formation essentially from minerals that should normally be soluble, but that become supersaturated. So if you have high urine concentration or low urine volume, those normally soluble minerals start to precipitate out, form crystals, and that's how you get the calculi. They can form really anywhere, but they typically form in the kidneys and then lodge further down. So your sites are the sites of normal constriction of the ureter, where it naturally narrows a little bit. That's where your stones are going to catch. So that could be at the pelvic-ureteric junction, the origin of the ureter, at the pelvic brim, where it crosses over the external iliac artery and you have a minor constriction, or at the entry into the bladder, the VUJ. And the presentation is really the most important thing you have to know. So you get renal colic, which is a severe stabbing acute flank pain, which can radiate to the back or towards the groin. So the site of the pain will actually depend on where it's lodged, roughly. But the idea is that it is a very, very severe, sharp pain. And they'll usually be like writhing in pain. It's so uncomfortable. If it is lodging up higher here, that's when you get more of the back flank pain. If it lodges lower down here, that's when you get more of the groin pain. And in between, you get loin to groin, which is the classic sort of buzzword for renal colic. So the pain actually radiates from the loin up down to the groin. And that's sort of tracking the movement, I guess, of the stone. They can also get nausea and vomiting, I think just largely related to the severity of the pain, because it is that bad. And also hematuria. So I think 90% will have hematuria, but it's microscopic, so it's usually not visible. If you did a dipstick, you might detect it, but they won't come in complaining of hematuria usually. Usually it is just the pain. There are some other things that you can get. So fever, if it is associated with a UTI, and that's a particular type of stone, struvite stones. They can get urinary frequency or urgency if the stone is irritating the bladder, or tachycardia, again, either from the severity of the pain, or it can indicate urosepsis. So if there's been an infection and that's gotten into the blood, you'd get tachycardia as well. But more likely it's just pain related. Do we need to know how dialysis works, as in osmosis, diffusion, and pressure, etc.? We didn't talk much about dialysis last year, I don't think. Gavin, Kevin?
No, you don't really need to know too much about it. I think just know it exists. Yeah, know it exists. Know there's like two types, peritoneal and hemodialysis. But hemodialysis, and that's basically what you need to know. And it's used for like CKD. That's it, basically.
Yeah, it wasn't really emphasized for us.
The phys of it, I don't think is important.
Yeah, I guess the one thing to know is that you need an arteriovenous fistula, an AV fistula in the wrist, where they connect together an artery and a vein. And the only reason you need to know it is because you look for it in the OSCEs, in the renal exam. But that's it. I don't think we talked much about dialysis last year. Okay, so the types of stones. So the most common types of stones you get are the calcium stones, calcium oxalate or calcium phosphate. And that can be due to like high levels of calcium in the blood. But most people don't actually have an underlying calcium problem. It's actually just usually due to like supersaturation from dehydration or something. The other types that you can get slightly less common, or actually much less common, are uric acid stones. I think this is something like 10 to 15% of stones. And that's if they have like systemic gout. So if they have high uric acid levels throughout the body, then they're also going to have high uric acid levels in their urine, and that can precipitate out as a stone. If someone has chronic or recurrent UTIs, you can get something called a struvite stone. The most important thing to know for that is just that it is associated with infection. So you might see a fever with it as well. And then there's cystine stones, which are very rare. They're due to a genetic defect. You probably don't need to know them. The main ones to know are calcium. The pathophys is just supersaturation of urine, and there are 4 things that can sort of cause or trigger supersaturation. You can have decreased urine volume, so most commonly due to like dehydration. You can have increased urine concentration, so they might be eating a lot of protein, which would cause uric acid, or they could have high salt, and that would just increase the general concentration. Decreased inhibitory mediators like citrate and magnesium, you don't really have to know too much about, or altered pH. In terms of risk factors, like I've listed them here, the ones that were given in the lecture. But really the main thing to know is the dehydration idea. So the classic presentation of renal calculi will be like a male, middle-aged, like construction worker. They've been working out in the heat all day. They barely drank water. They're dehydrated, and then as a result, they get stones. That's really your classic one. So that would be probably a calcium stone, just because they're the most common. Uric acid stones have their own risk factors because gout is its own sort of category, and that's where you have the specific dietary things, which again, you don't have to worry too much about this year. It's more of a next year problem. But if you can remember sort of dehydration, gout, UTI, that's really all you have to know in terms of causes. The way that you find renal calculi, so you could do a dipstick for hematuria or for signs of UTI. There are methods of determining the type of stone, but usually we don't care because you essentially treat the same way. But you can do sort of serum levels of different minerals, of uric acid, or you can do urine levels by doing a 24-hour urine collection. But mainly what will happen is just some kind of imaging to sort of look for the stone. It can be X-ray or CT, but CT is usually preferred just because X-rays won't show anything other than a calcium stone very well, because X-rays rely on that calcium density, right? Whereas the others are not going to show up as well. But if you have a young person, it's also not ideal to do CT because of radiation. And because most stones are calcium, they will often just do like a renal X-ray and hope to find the stone there. If they don't find it, then they might consider a CT. Acute management, most stones will pass spontaneously. So if someone comes into ED with the classic loin to groin severe stabbing pain, you usually just give them some analgesia, some antiemetics if they're vomiting, and some IV fluids. The IV fluids to compensate for the vomiting, and also just because one of the ways we try to fix a stone is to flush it out. So you'd either tell the person to drink a lot of water, or you just pump them full of water. And either way, you're just hoping to sort of flush it out with the urine. If that doesn't work, there are additional things that you can do. Antibiotics you might do for a UTI if it's a struvite stone. The main other methods though are alpha blockers. So you can use something called tamsulosin, and that's going to sort of help relax the ureter essentially to try to help promote stone passage. There are also other things like surgical decompression. So if you have a stone blocking the ureter, and that's causing hydroureter and hydronephrosis, so reflux of urine back up, that's going to cause symptoms and cause more problems, including kidney damage, than the stone itself. So you can actually decompress with a needle into the kidney through the abdomen, and you just sort of drain out some of the fluid if you're concerned about that. You can also surgically remove the stone. So you can, there's like, it's called like shockwave lithotripsy. So you shock it with sonic waves in the hopes of crushing the stone into smaller bits that can then pass spontaneously. You can also do it with a laser, so sticking like an endoscope up, not very pleasant, and lasering the stone. Or you can even do physical like crushing if you're doing like an open surgery, which obviously you're reserving for like worst case scenarios. Most will resolve with the help of some fluid and maybe tamsulosin. Okay, incontinence. Incontinence is talked about in phys for you guys, but it's really, I don't know, it's not a huge thing in third year, maybe fourth year in GP. But the main thing to know, because incontinence confused me a lot in second year, the main thing to know is that there's just really two important types. You've got your stress incontinence and your urge incontinence. They give you a massive list of other types of incontinence, which are much less important. And I guess it's just a good idea to know what the words mean, but you don't have to know much else about them in terms of like management and things like that. So mixed incontinence just refers to if you have both. Postural incontinence is referring to a postural change. So if you sit up or lie down and that causes incontinence. Overflow incontinence actually means when you have chronic obstruction and then eventually some leaks out because of the high pressure building up. Nocturnal enuresis is bedwetting essentially. Continuous is continuous. Insensible, you're not aware of it, so it's more of a neurological problem. Coital is associated with sex or orgasm. Functional is due to an actual functional issue. So if you can't get to the toilet in time, that like a sort of systemic mobility issue, elderly people, disabled people, that's a type of incontinence, but there's no real problem with the urinary tract, right? And then multifactorial, which is when you don't know. So it could just be a whole range of things. There is this sort of mnemonic for transient/reversible incontinence. So there are irreversible and reversible types, reversible being sort of just like temporary changes that you can get rid of, but that will cause incontinence in the moment. Delirium is kind of reversible/irreversible because it depends on if the delirium is reversible. Infection, so infection, when someone has UTI, remember the classic presentation is painful, frequent, smelly urine. And the frequency, if they just can't get to the toilet in time, it can cause incontinence. Atrophic vaginitis in postmenopausal females. Pharmaceuticals, so that is diuretics, obviously. If you're taking something that is making you pee, that is potentially going to increase the risk of incontinence, but also other things. Psychological is like depression if they're just, I don't know, they can't get to the toilet because they're so depressed. I don't know. It's just filling in the mnemonic. Excessive urine production, so hypoglycemia when we talk about diabetes, polyuria is one of the big symptoms that sort of is a red flag for diabetes initially. So they might just have, again, a lot of urine production. They might have restricted mobility, and that's your functional incontinence, or apparently stool impaction can cause incontinence. Pressure, maybe, I don't know. But that's the mnemonic, diapers. But really, again, just focus on stress and urge incontinence as the main ones. So stress incontinence is caused by weak pelvic floor muscles. So you've learnt about all of your pelvis anatomy, hopefully. Oh, actually, sorry, no, that's next sem, isn't it? Yeah, that's next sem. Never mind, you haven't learnt about your pelvic anatomy. But you have all these, you have these 3 pelvic floor muscles, and part of their job is actually to maintain urinary and fecal continence. So they contribute to the urethral sphincter that maintains continence. And so if you have weakening of those muscles, you get leakage. And that can be caused by a whole range of things. The most important one to know is childbirth. So a lot of women after giving birth, they sort of get tearing and damage to the fascia and the ligaments in the area, and that causes weakness of the pelvic floor, and a lot of them end up with long-term stress incontinence. The reason it's called stress, oh, you go.
No, you go. Sorry.
Oh, okay. The reason it's called stress incontinence is because you're incontinent when there is high intra-abdominal pressure or a stress, and that can be like sneezing, running, or strenuous activities like weightlifting. So some people like pee a little bit when they weightlift.
Yeah,
and that's a stress incontinence. Yeah.
I was just going to say about the muscles. Basically, they're like sling muscles that like they attach to your like spine kind of, and they wrap around your sphincter. And when you contract them, it like kinks the urethra, and so like that keeps you continent. But when they're like weak and they don't work, like your urethra is just like normal. It's like got an open lumen, you just get incontinent. But yeah, that's pretty much how it works.
Yeah, you'll also learn this better next time with like repro anatomy and pelvic anatomy. So don't stress too much if that made no sense. But it's kind of like an idea to know.
Just remember, pregnant women get stress incontinence. There are other causes, but that's really the main one. Caffeine consumption can just cause general incontinence because of suppression of ADH. And then menopause, constipation, blah, blah, blah. It's all relating to like pressure and function of the urinary tract. But the main one you have to know is pregnancy and childbirth. Treatments, lifestyle changes, you always mention first, and that can include cutting out caffeine and also all your regular lifestyle changes. Pelvic floor exercises is probably the big one. So this is like Kegel exercises where they practice tensing the pelvic floor muscles to try to strengthen the muscles and maintain continence. And then there's other like weird ones. So you can do like biofeedback or electrical stimulation of the area to try to strengthen the muscles. There's devices apparently. There's a really controversial urinary like sling that people had for a long time, and then it ended up causing all sorts of complications. So you don't really have to know too much about the surgical management, but one of the managements is a sling where it basically, so you have your urethra coming down and you attach a sling to it to try to create a kink in the urethra so that you can better suppress the area, and there's less effort for the pelvic floor muscles to have to actually close the sphincter. So you're sort of helping them out a little bit. Another option is a bulking agent, so to try to constrict the area a little bit to help maintain continence again. But those ones are all sort of like technical, you don't have to know too much about them. Urge incontinence. So urge incontinence is split further into neurogenic and non-neurogenic. Neurogenic obviously means it's a problem with the nerves. So this is caused by some neurologic dysfunction. And the specific dysfunction relates to the level of the nerve damage. So that's this table here. So you can have suprapontine, or essentially brain level problems, suprasacral, so spinal cord down to the sacrum, or sacral, spinal cord from the sacrum onwards. And so this is examples of each one. So cerebral palsy, it kind of makes sense if you think about it. Cerebral palsy, MS, Parkinson's, dementia, all of that can be associated with incontinence if it's happening to affect the area that maintains your continence. Spinal cord injuries, MS, and also lower down quarter equina syndrome and things like that will cause damage as well. There's slight differences in the types. I think this was in your lecture, but I wouldn't really worry too much about it if I was you. That lecture felt like it was too much. But if you have incontinence, remember that that is a risk factor for UTI and renal impairment. Hi, JJ.
So I got a question that was, do we need to remember this table?
It was in the lecture, but I didn't
Yeah,
learn it at the
I
time.
don't think
so
I
wouldn't
ever
worry too much.
learned it. I think there's like the sacral one is good to know. The general principle of if you have like overactivity or underactivity is kind of good to know. I think the idea is like know how it works, but you don't have to know this table because they won't. I don't think they'll ever go like they had a suprasacral injury. What's their urine like gonna look like? And if they do, it's like the one clue they give you rather than like they'll give you other clues that make it more obvious. So,
and actually, like you'll learn more about it when we do neuro, because that's probably this is very like neuro related. The idea is like it's overactivity if it's higher up because it's an upper motor neuron lesion, and then it's like underactivity if it's lower down at the sacral level because it's a lower motor neuron lesion. So when it's like sacral,
and those like your higher sentence as well. So you kind of just have like it just spazzes out a bit.
Yeah. So when you have a local lower down lesion, you're cutting off the detrusor muscle's supply, so it's not going to contract. So you just get sort of like a stiff, regular bladder. And then that's sort of going to cause incontinence because it'll fill up and not be able to expand as well. And then when it's higher up, it's like spasticity with your limbs. Like when you have an upper motor neuron, you get spastic. With the bladder, that's essentially what happens. You get detrusor muscle overactivity. So it will constrict with any little amount of urine that gets in there. And that's when you get incontinence as a result of overactivity. The suprasacral, it just has this weird thing where because it's kind of in between, you can kind of have simultaneous overactivity and also failure of the sphincter to relax. And then you can get the detrusor muscle contracting against a closed sphincter, which can be dangerous, can cause reflux back up and kidney damage. But yeah, I wouldn't worry too much about it. It'll make a little bit more sense once you learn neuro and like actual spinal cord stuff. Treatment wise, again, you would recommend like pelvic floor exercises, lifestyle changes, drink less water, things like that first. And then there are pharmacological managements, Botox injections into the detrusor if it's too stiff, or like agonists or antimuscarinics to try to stimulate the sympathetic activation. There's also bladder reconstructive surgery, which I've never really heard much about.
To just fully finish off answer that question, the only time I can remember ever like answering a question about like the neurological control of a kid like bladder was from like this urological surgeon this year. So that kind of gives you like a guide of who really cares about this stuff. And yeah, I don't think it's that critical to know. If you have a vague idea, it saves you from being embarrassed by a neurosurgeon next year. But beyond that,
you do have to know it for quarter equina syndrome in neuro next sem. But this sem, I wouldn't stress too much about it because it's really more of a neuro problem. And then you have non-neurogenic, which is essentially just we don't know what's happening. So it's not a nerve problem. It's not stress incontinence because it's going to happen sort of any time, not just when there's high intra-abdominal pressure. And we don't really know why. The bladder is just overactive for some reason. So you get your urgency, frequency, nocturia, incontinence. Basically, you can't hold on to your urine and it can't be explained by any other cause. So this is a diagnosis of exclusion. It's when you don't know what's going on. And the managements are basically the same. You don't know what's happening, so you just try a bit of everything and hope something works. But yeah, you don't have to know too much about that one. This is really just when you don't have a neurological diagnosis. But otherwise, it doesn't change much for you. Okay, Kakut. So this picture here is really all you need to know for Kakut. Like, I would not stress about anything else. So this picture, it shows you all the different types, and it also kind of illustrates the complications. So here we have a normal urinary tract, your 2 kidneys, 2 ureters, 1 per kidney, going into your bladder, entering at an oblique angle, very, very important to remember. And then that's a nice, normal, healthy system. You can get renal agenesis. So genesis being like the formation and stuff. So agenesis, no formation of a kidney. And this is to do with like issues with that initial Wolffian duct embryology stuff. So you have complete absence of one of your kidneys. And actually this can be asymptomatic because you only need one kidney to survive. So these people might not be symptomatic at all, and you might not pick it up until later in life, when if they sustain even a little bit of damage, it comes up as an AKI, right? Because if you lose a little bit of damage to both kidneys, it has to get to a point where you've lost 50% of function before it starts to show. Whereas if you have renal agenesis, you've already got 50% gone. So any damage there is going to cause problems. You can also have hypoplastic or dysplastic, which is basically just a small or malformed kidney. So this one could be slightly functional, or it could just be non-functional. MCDK, multicystic dysplastic kidney. We'll talk about polycystic kidney disease in a second. So this is essentially that, where your functional renal parenchyma is replaced by these big fluid-filled sacs that can do nothing, essentially. You can get duplex ureters, where you have 2 ureters for 1 kidney. You might think that's a great thing because now you have more space to like filter out your urine, but actually it can cause obstruction because they can tend to twist around each other and cut each other off. And so that will cause obstruction and kidney problems there. Then you've got your obstructions. So you can have a congenital sort of stricture or obstruction up here in the ureter or up at the pelviureteric junction, and that's going to cause hydronephrosis, so urine refluxing into the kidneys. Or you can get an obstruction lower down at the vesicoureteric junction. Oftentimes, if the ureter is not entering the bladder correctly, then you can get an obstruction there, and that will cause hydroureter, so urine reflux into the ureter. And then if it's bad enough, if it's untreated, it will eventually cause hydronephrosis, urine reflux all the way up into the kidneys. We also have posterior urethral valve, which we mentioned as a cause of obstruction. So that's down at the urethra, and it's sort of just like a flap of tissue that is going to cause obstruction. You get filling of the bladder, hydroureter, hydronephrosis. They all sort of end up as the ultimately ending up at hydronephrosis. So this is all of that in words, basically. So you can have a read of that if you'd like. The unilateral renal agenesis is an issue with the ureteric bud coming out of the Wolffian duct. The problem with Acute, or I guess it depends on which type. So these ones will have issues with your hydroureter and your hydronephrosis. The other ones will have issues with renal failure. So your congenital anomalies, they account for 1/3 of anomalies detected by fetal ultrasound. So it's actually quite a big factor. And there's 2 main mechanisms that we sort of postulate. I don't know how proven these are, but the idea is we can potentially have mutations in genes that affect your embryology, or it could be like a feto-maternal environment problem. So some external factor that's contributed to your anomaly. The issues with Acute that you have to know about are that the first few types can cause renal failure because you don't have enough functioning renal tissue. And the last couple types where you've got the obstruction, they will cause hydroureter and hydronephrosis. And hydronephrosis will cause nephron damage because remember, high pressure running through the nephrons is not good after a while. And in someone who has really severe pelviureteric junction obstruction, they can end up with like the kidney sort of just becomes a big cyst in itself. Like all the nephrons have died inside and you end up with just like a capsule of fluid. But that would be very end stage and we would really hope to treat before it gets to that point. Okay, I think this is the last thing that we're going to talk about, polycystic kidney disease. So I looked this up for images and it was really very gross. So feel free to look it up in your own time if you'd like, but it's quite unpleasant. And essentially what happens is you get all of this cystic formation, so these giant fluid-filled sacs that replace the renal parenchyma. So this would be a normal looking kidney, and then from the outside it would look like this, and if you looked at the inside you can see there's literally no functional kidney, like it is completely cystic. And what happens is all of these cysts cause the kidney to become very large too. So it can get up to 10 times normal. There's some photos comparing a normal versus a cystic, and it's pretty insane how big it gets. But more importantly, the loss of the functional renal tissue causes end-stage renal failure. It's an autosomal dominant inherited condition, and these are the genes that are involved. I wouldn't bother learning too much about them, but just knowing what they are and that they essentially regulate like cell cycle structure and things like that. So if you have issues with them, you get cysts. The clinical presentation is due to the size largely, so they'll present with flank pain because the big kidneys are going to like press on nerves. And they also tend to get hypertension because you have kind of like CKD, low GFR, RAS activation, and then hypertension. They can get hematuria if a cyst ruptures, and they can also get UTI symptoms if a cyst becomes infected, and that would be pyelonephritis because it's way up. And with polycystic kidney disease, even though we talk about the kidneys most, there's also, you can get cysts really anywhere in the body. So the important ones to know are intracranial aneurysms, so berry aneurysms, which is an emergency because they can get intracranial bleeding. They can get heart problems, mitral valve prolapse, regurg, and aortic issues as well. You can get cysts in the liver, which would cause abdo pain, diverticuli, which are little outpouchings of colon, and then all sorts of other less common sites. The diagnosis of polycystic kidney disease is by renal ultrasound, and there's varying thresholds depending on what age and risk population you're in. But essentially, this is what you see. You would see fluid-filled sacs, you'd count them up, and then you'd see if they meet the criteria. You can see it really doesn't take many to be diagnosed, and polycystic kidneys, they tend to actually have much more than just this threshold. And the reason the threshold is higher for older patients is because it is actually normal to form a cyst or two as you age, but any more than 4 is going to be considered abnormal. The management of it, similar to management of any renal condition, really is to try to control blood pressure and just manage complications. So your classic lifestyle stuff, antihypertensive medications, so your ACE inhibitors and ARBs, increasing water intake. So there's this thing where ADH actually promotes cyst formation, apparently. So you would decrease your water intake to decrease ADH release. And also there's ADH antagonists that could be used to try to reduce the progression, but that would be in severe cases. And then if you have a UTI or some kind of infection, you would treat that. But once end-stage renal failure is reached, again, your only options really are dialysis and transplantation. Okay, so there is a bit of OSCE stuff. It's not too long, so we'll go through it quickly. Very brief, so just history, exam, and dipstick. They're the 3 things you have to be able to do. The renal history, I group it into 4 categories, 3 questions each. So you think about stream first. Is the stream as good as it used to be, or is it poorer? And that could indicate obstruction. Is there hesitancy? Are they slow to start? Or is there dribbling? Are they slow to end? And that can also, this is all really related to BPH as your main cause. Urgency questions. So do they feel like they have to go immediately, or they'll be at risk of having an accident? That would be urgency. Or have they actually wet themselves? That's incontinence. And then you can also ask about pis en deux, which is, do they ever go and then immediately feel like they have to go again? And that's an incontinence problem. Quantity you'd ask about. So quantity can be due to frequency. So if they're going more often, or the actual volume. Has there been a change in the total volume of urine that they're producing in the day? And if they're producing lots of urine, one of the ways to quantify it is if they're having to wake up at night. So if there's nocturia. And you would also ask about the appearance. That's pretty important. So if there's been a color change, darkening might be jaundice. Blood could indicate PCKD or like UTI even. Smell, if it's gone sort of foul smelling, that's a sign of UTI. And if it's frothy, that indicates protein. So it could be proteinuria. These are sort of the causes of each of those sort of changes. So if they have high frequency, but normal overall amount, or higher overall amount, it can be due to fluid intake, diabetes, diuretic use, things that just increase how much you have to pee. But if they have increased frequency and reduced volume, it's more likely to be like an obstruction problem, a small bladder, or a UTI. So high frequency and urgency, but less volume. Oliguria and anuria essentially are going to relate to renal failure. But when it's anuria, you have to think about severe total obstruction. So most likely just renal artery occlusion. Stream and appearance. So if it's changed color, the main ones to know are if it's pink or red, because that's going to be blood. Dark brown could be your jaundice, so the bile and urobilinogen. And then if it's weird, funky colors, it's probably dyes or drugs. Frothy is protein. Stream impairment is your obstruction, and the main one you have to know about is BPH. Urgency is related to UTI, and incontinence, we've already talked about, has all sorts of causes. The rest of the renal history I group into pain, systemic stuff, mouth stuff, and peripheral stuff. So pain, you ask specifically about loin pain, loin to groin pain, and dysuria, urinating pain. And then systemic stuff, you ask about fever, so for infection. Fatigue can be related to really anything, but it could be CKD, anemia, and uremia. Breathlessness could be caused by the metabolic acidosis in CKD. The mouth stuff, anorexia, so they don't want to eat, hiccuping, which is a late CKD sign, or vomiting, again, related to CKD or AKI. And then peripheral things, itch, bruising, edema, that's again sort of accumulation of nitrogenous wastes in itch and bruising, and edema, fluid retention. Other aspects you'd ask about, your usual past medical history, family history. Medication use is quite important in renal because there's a lot of relevance, but otherwise not too much. The main ones to look out for are hypertension and diabetes, because remember, they're your big predisposing factors for CKD. The exam for renal is very close to the abdo exam with minor changes. So general inspection, you look at body build, pain, distress as you normally would, but you also look for your CKD complications. So hyperventilation in metabolic acidosis, they breathe rapidly, and your uremia signs. So the hiccups, uremic fetor apparently is like a fishy breath that they get, the sallow complexion of uremic tinge, and mental state changes if they've got that delirium. Sunken orbits. So in the renal exam, the other thing you're really looking for is dehydration as an important cause. So sunken orbits could be a sign of that. In the hands, you look for different types of stripes on the nails, basically. Merkes lines, Mies lines, half and half nails. You can take a look at some pictures of each of these. Tissue turgor is again going to indicate dehydration. So you just pinch the skin up, and it should snap back really quickly. It's a really poor test though, because in elderly people, it's naturally slower because of like collagen changes. So in young people, it can be a good sign. If it's slow, it might be dehydration. In elderly people, it's not so useful. You look for pale palmar creases. So it's important to actually like press and sort of stretch out the creases when you're looking for palmar creases. And that can indicate anemia. And then asterixis, arms up 30 seconds, and you're looking for the flap in CKD. While they're doing, so the way I do it is while they're doing the asterixis, while you're holding for 30 seconds, you take that time to look at the arms and even the face so that you're not wasting time. Usually they'll just tell you it's fine to put the hands down, but if they want it, do other stuff during that time. So during that time, you can take a look at the arms and you look for bruising or scratch marks, which are your CKD signs. And importantly, your AV fistula, which is where they've sort of fused together an artery and a vein for hemodialysis. So if you see that, chances are they've already got a renal problem. Then you look in the face, and there's really two things you look for in the eyes, jaundice and anemia. You pretty much always look for those two things. And then in the mouth, you can look for hydration issues, ulcers, gum hyperplasia, which can apparently be caused by transplant drugs, and thrush from immunosuppression in CKD. In the neck, you'd listen for carotid bruits, because remember that renal artery stenosis and occlusion is related to systemic atherosclerosis. So if they have occlusion of the renal arteries, chances are they have occlusion of other arteries as well. So you'd listen for carotid bruits, and that could give you a sign. And you also check the JVP, because again, we're concerned about dehydration. So if the JVP is not visible at 45 degrees, they're likely to be quite dehydrated. And you can actually keep lying them down flatter and flatter until you can see it. And the flatter they have to be, the more dehydrated they are. Then we get to sort of the good stuff, the back and the abdomen. So in the back, you look for any scarring for like nephrectomy, but you do your punch down the spine. So just tapping with the back of the palm. And that's going to be your renal osteodystrophy, so your bone disease. You do Murphy's kidney punch, so you sort of buffer with your hand and then you tap over each kidney, and tenderness there can indicate renal infection. And you'd also sort of press in the sacrum for sacral edema. In the abdomen, you sort of just do a regular abdo exam, plus or minus a few things. So you do your redness, rashes, scars, or swelling. So you always mention those things. You want to look for bruising. You want to look for a catheter that's been put in suprapubically. because obviously that will indicate renal problems. Any obvious bulges that you can see in the abdomen could potentially indicate a transplant, because when you do a renal transplant, it's not placed in the same regular place as the kidneys sit, so you can actually see a bulge. Or distension. If they have water retention, they might have ascites. Then you palpate, so you do your normal 9 regions superficially, then you do those same 9 regions deeply for masses, and then you palpate all your organs, liver, spleen, and you block the kidneys, most important. You can also palpate for the bladder. I usually don't, because I'll usually just percuss for the bladder, but you can apparently, and you just have to warn the patient before you do it, because you can, you know, trigger incontinence if you're pushing on their bladder. So you sort of just essentially approach, so say they're lying down like this, you sort of approach and just press above the bladder. You should not be able to feel it. Even if it's really distended, you usually often can't feel it. So it's kind of a pointless test. But you might also palpate for the aorta while you're there, and then you percuss for the liver, percuss for the spleen, percuss for the bladder, and then percuss for shifting dullness, percuss everywhere. Auscultation, you listen for the aorta and the renal arteries for bruits, again for the same reason. Obviously renal bruits are quite a problem, because that's going to be renal artery stenosis and cause your hypoperfusion and pre-renal AKI. But again, if you have aortic issues, chances are you're at higher risk of renal artery issues as well. Vascular problems are systemic, they don't tend to be local. Then you look at the legs, always finish up with the legs, and you look for edema, bruising, scratch marks, the same sort of things that you look for in the arms, but just in the legs. And edema, again, you're looking at fluid retention. The last thing is the urine dipstick. So this is the method. I have listed it out here. You'll learn it and you'll get to practice it, I'm sure. But essentially, there's a couple key points. Hand hygiene, put your gloves on, because you don't want to get that on your hands. You comment first on the macroscopic appearance. So before you even take the lid off, you look at it in the jug and you comment on the color, if it's cloudy, if there's sediment, if there's blood. You have to check the expiry date on the test strips. People always forget that. So you check it, take one out, and then put the lid back on, because if you're trying to read the bottle while the lid is off, you're going to end up pouring the strips everywhere. So you put the lid back on, you hold out your strip, dip it in the little urine pot, and then put the lid back on the urine pot, because you don't want that spilling. And then you essentially just wait. So the bottle itself, I'll show you a picture of this, what's on the bottle actually. It looks like this. There's a sticker on the bottle, and this basically gives you the answers. So along here, there's times, and you have to read them off at specific times. So once you've dipped your stick into the urine, you start a timer, or you mentally start a timer, I guess. And you just want to sort of read them off at the appropriate time. So you go down the bottle and reading off the strips for the color change. Once you've done that, then you have to interpret the results. And this table here is really everything that you have to know. So familiarize yourself with what the strip looks like, so you know what everything is talking about, and then just be able to correlate changes with pathology. So if they have glucose in their urine, you shouldn't have that, because it should get reabsorbed. So that means they have excess glucose, it's diabetes. If they've got bilirubin or urobilinogen, you've got your jaundice. They can actually differentiate obstructive versus hemolytic, which is pre-hepatic. And then nitrites, we mentioned in UTI, micro yesterday, as a sign of gram-negative bacteria. Leukocytes will also indicate infection. Ketones will indicate starvation or DKA. Or if they're trendy and doing the keto diet, they will have ketones in their urine as well. Blood, all sorts of causes, and actually high vitamin C intake can cause false negatives in blood, which is interesting, and menstruation can cause a false positive for obvious reasons. High pH can also be a whole bunch of things, but UTI is probably the most important one to know about. Protein is going to be your nephrotic syndrome or other systemic things, fever/exercise, but really you have to know about nephrotic syndrome. And the last one is specific gravity. And specific gravity is kind of just talking about the concentration. So if it's high, they might be dehydrated. Okay, and that is it. That is the end of renal pathology and OSCE and the end of the renal system. Does anyone have any questions? Our remaining audience members. Oh, we've accumulated more. Does anyone have any questions? I'll stop the recording if I can work out how.